start with a territorial. I'm just going to start with a territorial acknowledgement. So I'm coming to you today from Newfoundland and Labrador, and I would like to acknowledge the island of Newfoundland as the ancestral homeland of the Beothuk and Mi'kmaq people, and Labrador as the ancestral homeland of the Innu and Inuit. I encourage you all to use the chat to tell us where you are joining us from and to share a land acknowledgement as well. So welcome everyone. This is our third session in the National Seminar Series for our Geriatric Psychiatry subspecialty residents. I am so thrilled today to have Dr. Lillian Thorpe join us. I just can't even get started with her accomplishments. There's so many, but just to briefly summarize a little bit about her. She is actively involved in MAiD-related clinical work with over 800 assessments and provisions. She's involved in teaching, research, and graduate supervision regarding MAiD. She's a member of the Health Canada MAiD Practice Standards Task Group, a member of the Canadian Association of MAiD Assessors and Providers, and she's developing a national curriculum on assessing capacity and vulnerability. And she's also a member of the CAMAP Guidelines Working Group on MAiD assessments for people with chronic complex conditions. I heard this talk or some variation of it at the CAGP, and I just knew we had to bring it to our subspecialty residents and to those who weren't able to join for that talk on MAiD at the CAGP. I think we could go on for 2 hours. She kindly agreed to talk for an hour. I'm so thrilled to have her. And then maybe what we can do is if there's any questions, we can put them in the chat. We can have some discussion if that's possible. And yeah, let's just take it from there. Are you able to show us your slides, Dr. Thorpe? I think I enabled you.
Okay, can you see them?
Indeed, I can. Yep.
Perfect.
Fantastic. Thank you.
Okay, thank you very much, everybody. And Catherine, you're going to be bored because it's basically the same presentation with the exception of one slide I corrected mistakes on.
Okay.
So prepare to be bored or ask questions. So thanks very much, everybody. It's nice to talk to you folks. And it is a good topic. It's what all of us, or many of us, are preoccupied with because of current challenges, but also greater challenges coming in the new year with changes in the law allowing for people with sole mental illness to access this. So you can just imagine how difficult it has been just to start this process in 2016. It got worse, more difficult in 2021 when people no longer required having reasonably foreseeable natural death. So we're all started seeing a lot of people with comorbid mental illness and chronic health conditions. And then as of next March, we are going to have legal MAiD for sole mental illness. So that is why I'm on the Health Canada group that is looking at practice guidelines, because it is very difficult to say no to people sometimes, and it is helpful for us to have guidelines of what's appropriate for us to be able to then be able to say it is reasonable to have a number of trials and maybe take quite a while before making a decision in people who have a lot of strong wishes to die, but most of these actually do get better with time, but don't have that insight. So that being said, my background is I did do my MD in Toronto, did a master's in Toronto as well, and then ended up in Saskatoon where my husband was teaching at university, and I did my PhD in epidemiology. So that's my background, but some of you know, now I'm just trying to shift my slides. Oh, there we go. Okay, so in terms of disclosures, I am, as you heard, I'm involved in training guidelines and Health Canada curricula. And some of you may know that I was actually part of the founding and board member of the CAGP until 2019. So I was part of the group that actually got it started, the founding. I was the head of the section on geriatric psychiatry of the Canadian Psychiatric Association. And at that point, we got together and decided we needed an Academy of Geriatric Psychiatry. And I was part of the specialty committee that helped design the guidelines for geriatric psychiatry. So that's my Sorry, was there a question there?
No, I was just clapping for your accomplishments in that area.
Oh my goodness. Okay, so I'm going to give credit to some of my colleagues that have been helping me develop some of the guidelines for complex capacity assessments, many of which are old people, of course. Madeline Lee is in Toronto, and she is a psychiatrist there at the University Health Network. She is amazing and does a lot of work. Justine Dembo, also in Toronto, very involved in setting up the expert panel guidelines for MAiD for soul and mental illness. And then some of the others are part of our curriculum capacity and vulnerability working group. So I'm using some of the slides that we as a group have been developing. So what we're going to do is talk a little bit about MAiD within the continuum of end-of-life processes in geriatric psychiatry, and talk a bit about the roles of geriatric psychiatry in MAiD, and then talk a bit about some of those clinical issues, which are frailty, capacity assessments, dementia, and advanced consent. And I was invited to present to the Senate on advanced consent for MAiD a few months ago, which is much more complicated than people think, because as people develop their advanced consent guideline wishes, that may be a long time before they actually get to that point, and their wishes often change, and by the time they get there, they may no longer voice what they wanted many years ago. And so it's actually quite complex. If anyone's interested in this, I have a lot of stuff we could talk about. So this is what we're going to do. MAiD is obviously a challenging thing, and we balance our wishes for choice, autonomy and choice, with protection, and we really don't want to go this way. And Sir William Osler was famously quoted as having said that an institute should be established to which men aged 60 years should retire for a year's quiet contemplation before a peaceful departure by chloroform. So we forget when we talk about William Osler that there was a lot of ageist stuff happening, and we really don't want MAiD to become part of that expectation that older people after a certain age bump themselves off or help with getting themselves bumped off. Now, this thing is balanced by people's wishes for autonomy. So many people feel strongly they should have autonomy about end of life. And we see a lot of this, that people feel their life's endings are difficult. They should be able to have a choice in how they die. So there's that balance between this and equal, maybe not quite equal numbers, but people equally strongly wishing that in end-of-life situations, we should care more, not kill, and that we need more palliative care. So there's a big schism between wishes for people who have a larger wish for the autonomy side of the spectrum versus those more in the beneficence and caring part of the spectrum. And I think for all of us, we are torn individually between those all the time. Those of us who are involved with MAiD, which has taken much of my life since the last few years, and I think all of us should be willing to get involved in at least assessments, because we have a lot to say about this, and we often can help people figure out things at end-of-life decision-making and capacity that the physicians involved, which include family physicians and anesthetists and surgeons, lots of them involved in MAiD, don't have that full understanding that we have. So I think we should remain involved in at least assessments. Okay, so this gives you an example of why MAiD is really the end stage of a process that is a bit problematic long before that in terms of end-of-life decisions. This is a patient of mine I saw. She is actually, well, she's known to my family. My father lives across from her ex-husband, also very high up in the hierarchy in the law faculty. He's died now. So this is a retired judge who always was very high functioning. She's developed early dementia, ended up in our hospital, very aware she's dementing, did not want to get there, had not been eating much. So her adult children felt that not eating would be suicide. They were very Catholic, and they brought her to hospital so that she could be made to eat more because they felt she needed to live. And she told me that she knew she was going to get worse. She knew she had dementia. She was hoping to gradually eat less because she wanted to die a natural death before her dementia worsened. She was very pleasant. She was not depressed. She very, very aware of wanting a choice. Now, she was also Catholic. She would not have wanted MAiD, but she wanted to die a death, a peaceful death, before she became demented. So big meetings with her family, talking about least restrictive policies. That's our policy in the health region. We recommend against force feeding, and the family very demanding of the most responsible physician to insert a feeding tube and get her forced to eat so she could live. And she was eventually discharged with a feeding tube against her wishes to long-term care, where she still is. So this is something that's happening less now than it used to, but is clearly not what we should be doing and what we should be supporting. So I think sometimes that some of our processes that have forced people to live when they don't want to live by natural means has led to having MAiD laws happen. So there are many non-beneficial treatments in hospital at the end of life. This has been well documented. I see people in long-term care. So I go into long-term care, I look after all the consults at our acute care hospitals that are geriatric, and I do MAiD assessments. I see a lot of people on huge numbers of medications at the end of life. We've done projects on it, there are publications on this. But this happens. People having 24 drugs at the end of life. I get a consult from them being agitated and refusing medication. So this is very common, and less common than it was, but it's still there. And we need to have very careful discussions with our families and our patients before they're very demented about what they want at the end of life. So we don't end up in a situation where people are being forced to take all kinds of drugs and they're dying. So here we go, end of life. What I see is MAiD within the context of a continuum, that we need to be looking at this within our beginning to deprescribe. So deprescribing less drugs for people who are clearly towards the end of their life, that may not be improving the quality of life anymore, or maybe not even the length of life left, focusing more on the functional improvement, what's important to our patients. Not necessarily us thinking how long they live, but what's important to them, balancing the side effects and interventions, and looking at the evidence available on time needed to benefit of intervention. So our older patients who are on lipid-lowering agents that are at the last year, 6 months to year of their lives, what is the evidence that this will actually improve? Pretty darn minimal. So we're focusing then also on decreasing active interventions with our patients who often tell us very clearly these are not improving their quality of life. So a woman I was just talking to a few days ago, so she says that this chemotherapy makes her sick. She's barfing. She's nauseated all the time. This is not what she wants. She might live an extra 6 weeks. This is not her wish, and she wants to stop this. So we start there before we ever get to MAiD. And then when people are really closer to the dying process, we look at what is the palliative option for this person. And this doesn't always require inpatient palliative care beds. This sometimes means providing medications to decrease air hunger, to decrease the pain that they have, and making them comfortable where they are. And there's lots been written now on palliation within long-term care. So we all need to be more aware of this. And medical assistance in dying comes at the end of this graduated approach, that when life and living is so difficult that these things all have not helped, then our patients do have a legal right, and it's legal for them to be able to request this. And these are the laws that made it legal. You've all heard this, Bill C-14, June 6, 2016. We started preparing for this the year before. I was on the committee that designed our university-based processes, how we're going to deal with this. Bill C-7 last March took out the requirement for reasonably foreseeable natural death, and it also took out the mandatory waiting period, used to be 10 days, and a little bit of change with independent witnesses as well, and made a few more criteria for people without reasonably foreseeable natural death. That is now a minimum of a 90-day waiting period. And I say minimum because some of our patients read this as meaning the minute they turn 90 days after they have applied, they can have this. No, it means minimum of 90 days, which means that if we're not comfortable that they're making a decision that's really consistent with their previous wishes, that is well thought through and considered, we might wait much longer, as I have with some of our patients who've had spinal cord injury. We wait a lot longer than this. So Bill C7 said that there was a temporary exclusion of sole mental illness till March 17th, 2023, which is why we are now looking at guidelines with Health Canada, how we are going to even look at our practice when this comes. This is not going to be easy. So right now, eligibility means serious, incurable illness, disease, or disability. So bad stuff that is not getting better, that has already resulted in significant impact on this person's capability of living. So this is not someone with a little bit of trouble walking because of early ALS, early difficulties with Parkinson's. This is really someone who's already been impacted very significantly by this disorder that has affected their life. And then they have to have enduring physical or psychological suffering that's intolerable to them and that cannot be relieved under conditions they consider acceptable. So I've underlined this because this is already causing us challenges in our people without reasonably foreseeable natural death. So I have a woman who has Crohn's disease. So she's got considerable discomfort from Crohn's. It is serious disease and it's never fixed, cured completely, but she does not want to even consider trying biologics. And she has fixed ideas about this, but from everything that's been said by specialists, she might very well be much better with biologics and might be asymptomatic for the most part even. She doesn't want to try it. The way the laws are written, she doesn't have to. So I have some difficulty with this. What I've said to her is, I'm troubled by this. I think you might get better. This is something I don't think I'm comfortable jumping into. And she's accepted that. And it's been a year and a half since she initially approached us about this. And I hope she might consider at least a trial. Now, so we as providers and assessors don't have to do something that we think is not the right thing that's been well considered. She, though, has the right to ask for another assessment for someone else who might approve her. She hasn't done that. So if she really wanted to go ahead, she could ask for another assessor. I've had a second assessor see her, he agrees with me. So she hasn't asked for a third assessor, which she could. So just putting this into context. So reasonably foreseeable natural death already is very flexible. So it was based initially on Kay Carter, who had spinal stenosis in her 80s, likely was going to live for a few more years yet. So it never said it had to be imminent death. It never said 6 months. It always said reasonably foreseeable, taking into account all of their medical circumstances. So this does mean, though, that our elderly, very elderly patients don't need a lot to get reasonably foreseeable natural death. So my 103-year-old, who applied for MAiD, by the way, so she applied for MAiD. She wanted to have the option. She applied to make sure she could prevent a difficult death if she didn't die naturally. And she said to me, I hope I don't need you, but I want to make sure if things get bad, you're there for me. And so we approved her. And she actually lived another 2 years. For the next 2 years, she would call my office every year. And you'd arrive there at her long-term care facility and she'd say, oh, good, you're still around. I still don't want you. I'm still okay, but I want to make sure you're still around, that in case things get bad. And she died naturally. So they don't need a lot. They often apply for this wanting a peaceful solution if they need it. And over half of my patients don't ever do this. They just want to know there's an option. And this is especially our anxious patients who are very afraid of difficult dying process. So anyway, so the reason I mention this is reasonably foreseeable natural death already very fluid. So it's very much context based. But for our elderly patients, they don't need a lot to reach this criterion. Okay, other criteria are that 2 of us need to approve them, and that can include nurse practitioners. And 2 independent practitioners, it can't be somebody who is beholden to us. So I and my residents can't both be those 2 assessors because they're obviously not entirely free of my opinion. So 2 independent practitioners, nurse practitioners, or doctors. And then all sorts of other people can help with the process, but they can't give the drugs or do the formal assessments. So you have to be eligible for health services. We don't do MAiD tourism. You have to be 18 or older. You have to be able to give capable consent, including at the moment right before they have this, and has to be voluntary. So a lot of issues about voluntariness in people who already need a lot of care from family members who can sway them one way or the other. The most common swaying is to sway them against MAiD. What people worry about in the community is people swaying them to have MAiD, but it's actually the other way around usually. Okay, so these are the other requirements. And so here's why we all have to know about this. This is increasing. It looked linear up until the end of last year. So that's the federal data that we have is up until the end of 2021. We don't have 2022 yet because we're still in it. But we saw a fairly linear progression in numbers of people having MAiD. So you see this. Now, since January, we in Saskatchewan are seeing an exponential increase. My colleagues across the country are seeing similar things. So it is no longer looking linear, it's looking more exponential. None of us will be able to avoid having some connection with this. We're all going to see this, especially in psychiatry starting next March. And I think we should all agree to have some involvement because we can help figure out what it is that may be driving this. I'll give you an example. I saw a guy last week in acute care hospital who had COVID. And his COVID he was initially in ICU. He was then on ventilators for a while. He got off the vent. He got onto continuous pressure, oxygen. He got off that. He then was on constant oxygen. He eventually was able to have oxygen tubing. He was walking around every week. He was walking more. And the staff clearly said he was improving every week, but he had an outlook that was so negative. And he was an anxious guy. He actually denied he was getting better. And every evidence showed he was improving. So he felt strongly he would never get better. He would always be on oxygen. He would have a horrible life, end up in a long-term care facility, would never go home again. And so the first assessor approved him because he was so adamant and said he was able to tell him he had COVID and all this stuff. And I saw him and I said, this guy is really not making a careful, considered decision. He's absolutely petrified. He is not firing on all cylinders at this point because he's so anxious. He can't even see rationally what's happening with him, which is he's actually improving. And I said, no, he has to have some time. And he actually got started on escitalopram by one of my colleagues in that hospital because he was anxious, very anxious, and a fair number of depressive symptoms. And so I said he had to wait for a while. So without me, it would have been probably the nurse practitioner, who's lovely in our region, but she probably would have approved him. And so I think we need to be willing to get involved because we can add something. Okay, so this is what's happening with MAiD is older adults are the ones getting MAiD for the most part. Average age is in the 70s, the young old. There are a few very young people getting this. The youngest person I've assessed is 20 with a developmental condition and cystic fibrosis actually. And I've had a number of people in the 20s with cerebral palsy, but most of these are older people. And my oldest one I've assessed is a 103-year-old who never did it, but I've assessed a multiple 100-year-olds, some of whom, yes, have gone on to have MAiD. So this is something we as geriatric psychiatrists will be seeing. So, and it does vary a bit across the country who does this more. BC, surprise, surprise, of course, has the most cases of MAiD, and this is not age adjusted, but a lot of older people go there to retire. And then Quebec has a lot of cases. But you can see over time from 2019, this is our yellow mark is 2019. If you look at even each one of these years, there are more cases, but always this pattern that both Quebec and British Columbia have the highest cases. Now Saskatchewan is down here and Newfoundland is even lower. So some variations across the country, some age spectrum related issues there. When you have an old population, more cancers on that, but a little bit of a variation. And so who is doing these assessments? So most people who are doing MAiD assessments are in family medicine. And then there are some from palliative care, a lot of nurse practitioners doing this, anesthetists, internal medicine, there are surgeons doing this. And the reason I show this is that the understanding of the sort of pressures, the emotional factors that drive some of these requests are really not that well understood by our colleagues who are not involved in mental health care. And they're very, very well-meaning people, but it's very hard for them to get this, that people's functions and wishes are much driven sometimes by their emotional states. So we should be there to give advice at least and consult at least in these cases. It's helpful. So what are we seeing? So the suffering we're seeing that from our Saskatchewan data is actually the pain. We all thought we would see largely untreated pain, nausea, choking, loss of control, mobility, dyspnea, but it's actually these non-physical existential things. It's the loss of autonomy. It's the patient saying, I don't want to live when I sit in my poop. I can't get to the bathroom. I'm sitting there for 2 hours before a staff member comes and takes me to the bathroom because they're understaffed. This is much more driver of MAiD than these symptoms, which are largely, many of them, very more treatable, such as especially pain, nausea. So this kind of thing, I saw a woman on Monday who had end-stage Charcot-Marie tooth disease, and she lived in a wheelchair for more than 30 years. She has to eat now with her mouth right off the plate. She can't manage fork and knife anymore. She wants to live as long as possible, but she doesn't want to live. She absolutely cannot make any of her own choices anymore and has to go to long-term care. Very cheerful, lovely woman. So this is a more common thing in our patients. And you heard, I've seen over 800 assessments. I feel like there's nothing I haven't seen yet now. So the people who have, so this is just showing you from the national report. This is what it is. Loss of ability to engage in meaningful activities. That's what's driving MAiD. Loss of activity to perform activities of daily living. Those are the two top drivers. And they are higher than pain. So these are the things sometimes I've been able to help with getting people access to resources that can then have ways that they can still be able to participate with life. And one of my actually, this is a friend of mine who wanted to die. This is before MAiD. He wanted to go to Switzerland. He had a spinal cord injury, and for 3 years talked nothing except wanting to die. He got his electric wheelchair. He got his home updated so that he could go home on weekends to be with his wife. And he then had a number of very good years in a long-term care facility that was very, very accepting of his wishes for autonomy. He died eventually of sepsis, but he had a few really, really good years with adaptive strategies. Okay, so who dies with MAiD right now? It has been cancer up until end of 2021. This is starting to change with the law changing last March. So we're seeing more chronic illness in people who are applying for MAiD. So it was cancer and then other conditions, ALS. I've seen a heck of a lot of ALS. I've seen Creutzfeldt-Jakob disease. I've seen end-stage Parkinson's. These things we're seeing, but what we're now seeing more of is the chronic diseases that are coming along. So here's the neurological conditions. I know the whole ALS program really well now because of all the patients I've been assessing. So this is what we're seeing. The chronic illnesses that we're seeing are much more difficult. These are people who are socially isolated. They haven't had contact with friends, with co-workers, and they often don't know what the resources are. And so these are very intensive for us to work with. Many of them can actually live meaningful lives with addition of variety of resources and adaptive strategies. So why is this relevant to us? Well, okay, so dementia. A lot of people out there are telling us that they don't want to live if they get really demented. And there is definitely evidence that there's a high rate of suicide death after people are diagnosed with dementia. It's 53% higher than general population of older adults. And especially in the young old adults getting younger onset dementia, they know this. And this typically happens early in the first few days of a dementia diagnosis. So this is what's driving the wish for advanced care directives for MAiD right now, is people don't want to end up with advanced dementia long-term care. So frontotemporal dementia was associated in this study with the highest rate of suicide rate in these people. So this is just showing that graph from that same study, that the youngest males have the highest in suicide mortality after diagnosed with dementia. So we have to be aware of that. So, and then Sunnybrook, again, why this useful for us in geriatric psychiatry, this is older people. So of all the people they saw, 38%, so almost getting close to half, or 80 and over, older patients, and then very likely to have other chronic subacute conditions, and they're very frail. And there is a tendency across the country to see frailty as the major driver, major illness that people have that would make them eligible for MAiD. And all my patients in geriatric psychiatry are frail, so should all our patients have MAiD? And I think most of us work on getting our frail patients to a place where they can still have some good life. And I have some difficulty considering frailty as the major diagnosis that makes one eligible for MAiD. Okay, so what's our role? Well, we might have a role as one of the assessors. So clearly I've taken this role. I got voluntold to be part of this process because I was the person doing most of the complex capacity assessments across the health region, and they wanted someone with that expertise in the committee that developed the processes and standards for our health region. So I then became very involved. I was initially very opposed to MAiD, but I've obviously become very much part of that process. So you can be one of the assessors. You can be a provider. I do a bit of both. I do provisions for MAiD, less often than just the assessments. My more comfortable role is to support the families that are having MAiD and the patients, and my providers who are then giving the drugs. I like to be there and help that process. And I give support to others. So that's a role we could do. As psychiatrists, we can also play a role in assessing the capacity in these complex situations without doing a formal MAiD assessment, giving advice, giving guidance and informal support to our colleagues. So I provide a lot of support to my colleagues in the hospital. Much of what I do, of course, is totally unbillable, which is interesting when we're largely fee-for-service. But it's part of a role, being there for our colleagues who are struggling with their decisions. And one of my colleagues came to me a while back and really was very anti-MAiD, and he said, "I'm having a real crisis of conscience now because one of my neighbors had a life-ending health condition. He waited till everybody was out of the home, went to his garage, and blew his brains out." And I'm now feeling, wow, this has left this family with an incredible trauma. They got home, there were brains all over the ground, there were floor, there's blood everywhere, and this will always be with them. And this guy was dying of a difficult disease. Would it have been better for this guy to know that his family might have supported MAiD? And I think that's the kind of thing that we talk about. It's a factor. People are dying difficult deaths. What is risk minimization in these situations for our families around? And wow, we all have had people who have suicided, often really, really traumatizing for families and co-workers. So we can get involved in teaching, and a lot of the people I teach, I'm doing a lot of teaching community. Right after this talk, I'm doing another session on long-term care about MAiD. We don't know what we don't know. So our very lovely family physicians and nurse practitioners, they don't always know this, that people can have these moments of crisis in which they make these decisions, and these are not always the right decisions. And the nurse practitioner who approved the patient after patient came in with pneumonia superimposed on COPD, highly frantic, wanted MAiD, she approved. I got there, patient had had one dose of antibacterial drugs for the pneumonia. And I said, no, you can't go ahead yet. You have to wait until there's a bit of stabilization of this acutely upset patient that is asking for MAiD. But people don't know what they don't know. So we need to get out there and do our teaching and be out there for people. So I'm doing a lot of this. A lot of roles of also in looking at quality improvement. What do we do? What can we do that we can do better? There's a role in research and end of care. We have a number of projects going. There's one now going to start on multiple sclerosis and end of life. And there are many things we can do. One of the projects we've done is looked at why people apply for MAiD. What are the needs, the unmet needs? We're going to expand that project, looking at what are the unmet needs now, what should we be doing, what could we be doing? Okay, so assessments are not always straightforward. Some really are. Our patients are dying horrible cancer deaths. It's often a very straightforward assessments, but not always. So people have fluctuation in their wishes, which may be to do with pain or dyspnea. They're very, very upset and stressed. They ask for this. They have fluctuations. I have patients who every time they come in with COPD exacerbation want to die. And then once it's treated, they don't want to die anymore. And so if you don't know this happens, you see someone, you're very caring, you struggle to see them suffering, you may end up thinking this is a reasonable wish, but I think there's a lot of fluctuation we need to be aware of. So we have a lot of transient emotional responses, people who've just had spinal cord injuries. The woman I told you about, she was 46, she had 3 young children. I had a lot of counter-transference to her. She was a healthcare practitioner. And 3 kids, I have 3 kids. She had a spinal cord injury, and all her self-worth was tied to her performance and what she could do, not to herself. That's how she was raised. And so very transient, very upset, and this is the time we should not be making decisions. Okay, otherwise, complex conditions with mental health driving the request, but isn't the sole underlying condition. A lot of our concomitant mental illnesses are present in our track 2 patients that are not having reasonably foreseeable natural death. But the mental illness, the anxiety, it's driving this. And it's often not right up front. It's not always recognized by our colleagues. And complex things where the family all has really different wishes. Some want to support the family, some don't. And we all worry about ending up in court. And some of us, I end up doing medical legal assessments a lot and getting subpoenaed to court, and it's not much fun. So we have to document. What else makes this complex is if a person might live for a long time, because there's a lot more at stake with this decision. So somebody who might live another 30 years with a spinal cord injury, they're losing a lot of life if they have MAiD quickly. So the risk-benefit balance is much more complex. And then if they have very complex conditions, we don't fully understand them. And so there are a number of these that make these very complex, especially unclear capacity. We know capacity is gray, not black and white. How do we decide? Right now, I'm going to see someone a second time with my colleague. We're really feeling torn. This person has Alzheimer's. She's telling us she wants to die with MAiD, but has really difficulty expressing her wishes. Is it clear? Does she fully understand? This is difficult. We're going to see her another time. I'm really busy and I shouldn't have to go again. I'm going to go again. And because if she really is consistent, she knows she has dementia, she does have that right. So what's the trauma history? People have trauma. An Indigenous family of mine, the patient wanted to have pancreatic cancer, wanted to die a peaceful death. His wife, difficult trauma history, felt that MAiD was part of the white medical system. Again, traumatizing Indigenous communities. Very, very difficult. I ended up working a lot with our Indigenous health services, and we ended up developing a good compromise that was okay in the end, but it was challenging. So you see a lot of these other vulnerabilities that make us. The other one here is impact on others. So if somebody wants a death that is very impactful on other people, such as in this Indigenous man, this wife was very, very vulnerable. That again makes it very complex. Okay, so there are many areas of vulnerabilities we've been talking about in our national committees that we're working on this: societal things, community things, interpersonal things, and individual things. By the way, if anyone wants my slides, I'm going to, if I haven't already done that, give them to Catherine. and you can feel free to have those if you find them useful and adapt them to your own needs. So this just gives the guy an example, really challenging guy, terminal cancer, wanted to end his suffering. And he was also very concerned about impact on his wife, but he didn't want to suffer. Children agreed with him, his wife didn't. He completed the waiver of final consent, which is now legal since last March, that if you lose capacity, you can consent ahead of time if you're already approved and doing this in the near future. And we had a lot of challenge about, this colonial history of genocide, what's the impact on the wife. He was gradually getting more and more obtunded because he needed so many medications to keep him comfortable. He'd clearly said he wanted MAiD, but he'd also clearly told me that he was worried about his wife. So he had two conflicting wishes here. So we waited quite a while. We got Indigenous health services involved, social work involved, helping her cope to prepare for the death. So we did a lot of work. He was eventually completely obtunded, and only once he was completely obtunded, she said, yes, I'm okay to go ahead now. And once she said yes, we went ahead. Now, one could have legally gone ahead before that because he clearly told us that he wanted to go ahead, but we chose to wait. And in the end, we did this in our ceremonial room for Indigenous folks that we have at the Royal University Hospital. It's beautiful. We had an elder there. There were things that we tried to do as much as possible to make this a reasonable end for everyone. Anyway, I won't go through these all these other examples. I'll give you another example, though, of a man who was incarcerated man. We have in Saskatoon had the only person who had MAiD within a federal corrections institution, the only one so far. There have been two others that were assessed there but discharged done elsewhere, but we had the only one. And older guy who metastatic cancer, horrible life, no friends, and all his friends were within that correctional facility. And there are a lot of questions about how does incarceration affect voluntariness of health decisions. Now, he was quite, he had cancer, he was dying. He very much wanted to die with his friends from the prison being there. He didn't have anybody outside. I felt that he was voluntary, but we were pretty careful how we did this. I've also seen other people who were discharged to die in the community, and they had chosen this, and that was their choice to make their voluntary decision. So definitely clinical judgment comes in, and we have to do we need to use good clinical judgment. So the law can't tell us everything. We also have to use our judgment in knowing when a person is maybe not making a decision that is well considered and one they might have made in a good circumstance. So we have to decide if a person is eligible. Obviously, we talk with our patients, but we make this decision, and we can decide to defer our decision for a while until we're really sure that this is the decision that is well thought out by our patients. So you don't have to go ahead right away. So, there is a presumption of capacity in a legal sense. Capacity unless found to be incapable. However, with important decisions like this, it is the expectation that there is a careful documentation of discussion with a person to show that this person really does have capacity to make this decision, which is a life-ending decision. So we need to formally assess a person, document everything, and the more complex it is, the more we document. So it varies capacity over time. We all know this in geriatric psychiatry, that people are often more muddled late afternoon, by morning, they're often okay, late afternoon not. We have to assess people at their best. So make sure people are in as good a situation as they can before we assess them. And capacity is task and context specific. So Carol Cohen from Sunnybrook will talk to you more about this. And she's going to talk about capacity. So this is really important. So capacity, task, and context specific. So someone dying of an obvious cancer is a different context than someone might live for a long time. And mental illness alone doesn't mean you lose all capacity to make your own decisions. So we have fluctuations during the course of the day. We might decline. We might, during illness and they get better, we might gradually decline with Alzheimer's. So we have to be able to consistently communicate a choice, understand this choice, and appreciate fully the broad ramifications to yourself and, I would say, to others. Now, I argue a bit with the lawyers about this, but I feel that when something is important to a person, which is your family is important to you, that is also important that you consider that consequence. And the example of this is a patient of ours we saw who he married late in life. So he had a 12-year-old son. He wanted to have MAiD while his son was away with his grandparents. His son would come home and find him dead. And he'd never be able to say goodbye and always know that his father had not trusted him with this. And I felt he didn't fully appreciate the ramification of this. So we said, my colleague and I both said, right now, we're not comfortable, you fully get it. We need you to do some work with your son to prepare him for your death before we're comfortable going ahead with this. So I do feel that appreciation includes impact on the others that are important to you, that you have to understand that. And actually, I went to the CMPA about that, and they and in talking to them, we reminded ourselves that if I give a prescription of Viagra to an older guy who then understands Viagra, but if he goes and rapes someone, that I'm also liable for that decision I made to give this guy Viagra in a long-term care facility, for example. So we do even legally have some expectation of responsibility for the impact on others of choices we make for a particular patient. So the complexity, Carol will talk more about sort of the complexity of executive functioning and decision making. This is obviously very, very important. So how rigorous we have to be for MAiD assessments is depending on the decision. So it's always dependent on the context, and higher decisions need more rigor. So this is what I always like to talk to my assessors who are nurse practitioners and family physicians, that we have a certain abilities at a certain time and context, but we have to be given the information in a way that we understand it and can acquire and retain it. So this is an active process. And if you talk fast to somebody using complex language and long sentences and a lot of jargon, our patients may hear it, but they don't understand it. So this is an active process. And the decision they made is then further affected by their emotional state, the cognitive distortions they have, such as the guy I told you with COVID. He was absolutely convinced he will never get better. He was also convinced he wasn't getting better, which was not true. And so he had a major cognitive distortion that affected his decision, and the influences that act on those people, both for or against MAiD. So we as psychiatrists, we're more aware of this than others and need to get into thinking about those things. So for consent, Carol will talk more about this, but for MAiD specifically, we have to make sure they know their options of palliation, of the cancer treatments that are out there. What are the alternates to having MAiD as well? Do they understand it? Just saying, repeating something doesn't mean you understand it. Being able to rephrase it in your own words consistently. So this is the kind of thing we need to do. And what information we have to give is the information that a reasonable patient would want to know in the same situation. And we have to disclose common risks, but also serious risks that are rare. So that means in MAiD, if you give oral MAiD, so we don't do oral MAiD, but it's legal. But if you give oral MAiD, a lot of those cases fail because people vomit them up. They're very nauseating. They're barbiturates. They take hours to work, and then a person might be in a coma, but not dead. So that's a situation that's quite common with oral medications for MAiD. So this is why we don't do oral MAiD. In our area and across the country, very few people are doing this. We do just the intravenous MAiD. So we ourselves should have some knowledge and training, and we have impact on our decisions, what we understand and know. So I'm really happy I got invited to talk to you folks because it's important that we know these things. And we do a good job, and we conduct those interviews we have with our patients in a way that tries not to influence the choice that they make. So we want to have them make free choices as voluntary as possible, interviewing in a very open way that is not leading them. So non-directive interviewing, provision of information, and then make sure we see patients alone for at least part of our assessments, because there's always undue influence possibility there. So, in the way we interview people, obviously, make sure we interview them in a supportive setting, that we use appropriate language and volume and speed of presentation. Just now, I did an interview right before on visible facial features. So this person was lip reading. I used a plexiglass screen to interview this person because he used my lip reading of my lips with his hearing, and we also used a pocket talker. So we made sure that he could understand. So we have to make sure, as good as possible, the interview. And a lot of my residents start out using a lot of jargon. So you want to get away from jargon and don't use these double-barreled sentences with a lot of in that sentence and very soft, high pitch. For women, we talk higher. We lose high frequency hearing loss in aging process. So we have to talk lower, slower, and using simple language and short sentences. So here's where we, oh, this is the example I just told you about. So we're going to go into this. So frailty is the other issue in geriatric psychiatry. You know, most of our patients are frail. They would probably, most of them qualify for MAiD. They have a serious incurable situation. Yeah. They're often advanced state of irreversible decline. Yeah. And do they suffer? Yeah, sometimes. And sometimes their suffering can be remediated. And sometimes they haven't had the chance to have supportive resources because they're not in touch with those supports. And which is why over half of my patients never go for MAiD. So, yeah. So, anyway, so I won't give you my other examples, but we can, you can, maybe Catherine can find a way to hand these out to our residents. So we particularly have issues with comorbid mental illnesses, acute on chronic conditions, poor coping skills, a little bit of executive impairment, wish to avoid burdening our family, and unrecognized delirium, very common by my colleagues. They're often not seeing this. The nurse practitioner who approved right away, she actually didn't recognize this. And I won't go through all of this, but you can read some of these things. In Saskatchewan, our college says you have to have a clear and settled intention to end your life after due consideration. This is not in the law. I think it should be, because the law doesn't really make that clear. So we have to really, really follow that. Manitoba has this in too, and I don't think all the provinces do. Okay, so I'm going to go back to this, and undue influence always worsened by social isolation and more reliance on family. During the pandemic, people don't want to be a burden, and other kinds of things. So here we go. I'm not going to go through all these examples, but and the dementia and advanced requests, you know, this is often a challenge. And so I know we're close to end of our time. I have some up with waivers. So the waiver of final consent is not as simple as it sounds. A lot of our patients' families are really upset to feel they would cause the death by acting on this waiver. And so I've only done this twice, using a waiver for doing MAiD, because it's very difficult for family members. And then this is the House of Commons presentation I gave on advanced requests, which you'll see I did this in February, but it's very complicated because when you have people making a request long way ahead, they often don't know how much they can adapt to this. And then oftentimes a person you know, really don't know what they're going to be like. And then sometimes people in dementia are they don't know they have dementia anymore, can be quite happy, and they don't want to actually have MAiD. And sometimes they're very agitated and don't even take their oral medications, let alone have it taken IV. So complicated scenarios, which I put in there from my presentation to the House of Commons there. Actually, it might have been a Senate subcommittee. Okay, so this is, I'm not going to talk anymore for this, but go to the end and see if people have any questions. And where we go to the end. And okay, so I'm going to get this sent out. Do people have any questions for the last 5 minutes?
I have lots, but I'm going to open it up to the residents. So go ahead, residents.
Hi, thank you for your talk. This was really, really interesting. I guess, yeah, my anxiety about the whole subject lies on, the fact that people just with mental disorders now will be able to get it. And we've seen a few cases in CL, in Geriatric CL, where, I mean, there was this older woman who had maybe a mild Alzheimer's disease, and but she had really significant somatic symptom disorder, and she was very focused on abdominal pain, and that was the only thing she could talk about, think about. But she didn't respond to any pain medications, had been extensively involved with the chronic pain service, and then somebody proposed MAiD to her, and that was all she was talking about at that point. And we sort of left it at that. I was really doing a cross-sectional assessment. I wasn't going to be involved, but I left her room feeling very ambivalent about the whole thing, right? That functionally it was her thoughts that were limiting her ability to move, because in effect she could walk when she was not actually, when she was distracted. Or so I don't know. I'd love to hear your thoughts on that.
Well, that's a great example. And it's an example, sorry, I inhaled some of my hot drink here. But it's a good example because it's the distortion of her thinking that is driving the request. And so that without that distortion, she probably would not be making that request. And this is exactly why we need to be involved. So this case of the guy with COVID, I documented very clearly the whole story. I said this man should not have MAiD right now. So very hard for an assessor and a provider now to act on that MAiD with somebody very clearly saying this is a strong distortion. So we have a big role to play here, because they meanwhile, very, very important, we document this. So it didn't happen. So this case would have happened, and I put it right on the chart. I uploaded it. We have everything on electronic chart these days, right up there. Very, very hard for someone to go ahead with this without waiting for some time now. So this is the worry. It's a big worry, because we know the people that are doing this very well-meaning, and they don't like to see someone suffering. They're really caring people, but they don't always get those cognitive distortions.
But then I guess you can push the debate into, well, if they've had cognitive distortions their whole lives, right? And if they have consistently been distorted despite all treatment, then their suffering comes from that, right? And should that then allow them to receive MAiD?
So if the primary suffering is from their mental issue, mental disorder, or cognitive distortion, right now they wouldn't be eligible. They will be, though, as of March.
That's it. Yeah.
So as of March, they would be eligible. And so what's happening right now in the committee I'm on, the Health County Committee, we are adapting the special expert panel on MAiD for soul mental illness to put guidelines in that are going to say that for mental illness, because irremediability is very unclear, and many people actually get better most people get better from mental illness. And so we are recommending that this is going to take considerable acceptance of interventions tried for people before MAiD, so that it's not going to be like the current law says, only if you consider the intervention acceptable. But if people do not accept trials of reasonable interventions, we are not going to be able to say this is irremediable. And if you can't say it's irremediable, they're not eligible. So we're going to be recommending there have to be considerable trials of reasonable interventions before we consider this person eligible. That's going to go right in the guidelines. And it's going to all the colleges, the physicians and surgeons. And we're hoping all the colleges will agree to add this to their websites. And they have a choice not to, but. So, and that is a big issue. You have to be able to try things to know that's not going to get better. Like my woman with Crohn's disease, like I'm not convinced she's not going to get better. She's not willing to try biologics. Yeah, it's the worry though. Anybody else seen any MAiD cases in your group here?
If anyone hasn't seen cases, I just want to bring up one that I'm aware of. Somebody moved to long-term care, had COPD. Within the first, I think, 4 to 8 weeks, they had no access to Wi-Fi and felt that life wasn't worth living. And that's what worries me. That person did get MAiD, but I just wonder if we're going to be in a situation where all measures to enhance quality of life will be exhausted before we offer MAiD. And I don't know what to say about that, because some areas are so much better resourced than others. And I think everybody wants patients to die with dignity, but at what point do we say the social determinants of health are such that we can't allow for life with dignity? And that's the thing that really I struggle with.
Yeah, it is. It is a worry. And it's not possible to give people everything they want. So this woman I saw with Charcot-Marie-Tooth, she would need one-to-one caregivers 24/7 to keep her away from long-term care. She doesn't want to go long-term care. So you could say if she had access to money to pay for total private 24/7 care, we're talking 3 shifts of people at least, because then weekends as well. So that's incredibly expensive. Some of my patients have done that, like well-to-do patients. They don't want to go long-term care. They're paying a vast amount of money. So if she had money to do this, she actually wouldn't have MAiD. So you can't exactly say that we have to, that she's not eligible, because if she was rich to give total care, like, then she wouldn't have MAiD. So this is obviously the issue. And there are always going to be possibilities of new treatments. Are you going to say, well, we have to wait till something might come up in the next 20 years to treat you? So a tough balance and discussion with all of these cases.
So we're at 2:32. I'm not sure when the link is gonna shut down, but any final questions? This is such a great and timely topic, and your cases were so riveting. Does anybody have any final questions or comments? I will share the slides with everybody, and if anyone has further questions, maybe we can, if we don't get time today, maybe we can just get them forwarded to me and we can continue the discussion.
Did I send them to you already? I can't remember.
What's that?
Did I send them to you already?
No.
Oh, yeah, I'll send them to you. Okay.
Perfect.
Okay, well, hey guys, thank you very much. Thanks, Catherine, for inviting me, and have fun with the rest of the sessions.
And next year we'll give you 2 hours.
Oh, good. Yes, because then we could really do case-based discussion of those cases, do a lot of debate about what we should have done, what we could do, because you'll read those cases kind of interesting.
Absolutely. Thank you so much.
You're welcome. Bye,
Thank
guys.
you. Thank you so much.
You're welcome. See if I can exit myself here. Stop share. Leave.